Hello? Hi, can you guys hear me? My name's Dr. Chul Kim. I'm a local podiatrist with the Archstone Foot and Ankle Institute. And I'd like to thank you for inviting our office and our doctors, staff, to the lecture series today. I also want to thank the Miracle of Living staff and the community members who put this together. It's a wonderful program. And thank you for allowing us to be a part of it. I also like to welcome you guys to the lecture series and those watching from home through Zoom. Also my children, Miru and Hana. Hello. Before I introduce you to the speakers today, we're going to talk about feet and foot health, and I thought how that would relate to the miracle of living. The most important thing, one of the most important thing about life is the ability to be independent and be mobile. You want to go from point A to point B without the help of others, as long as you can, and that is one of the what the definition, in my opinion, of what living is. And what's the first thing that touches the ground when you go from point A to point B? It's the foot. So in my opinion, that is, we serve a valuable service for the medical needs of the community. And I hope you guys can learn some important things about foot and ankle health through the lecture today. The first lecturer, Dr. Gavin Tsuchida, he is locally homegrown from Torrance, California, through West High School. He graduated from New York College of Podiatric Medicine, was a resident, leading a team at New York Presbyterian in Queens. He is a board-certified surgeon, and he is also an expert in minimally invasive surgery, in addition to what he talks about today. And thank you. Welcome, Dr. Gavin.
Hello. Hi. Thank you, Dr. Kim, for the kind introduction. So I guess I'm starting this off with welcome to Happy Feet, guys, and let's get into it. So I don't have any financial disclosures. So let's start kind of at the basics with just a little bit of anatomy of the foot and ankle, because people may or may not know how complicated it gets. So the foot has 26 bones in it, and there's 2 in the ankle. So all of those bones interact with each other to create the 33 joints, and then all of those bones are held together by the ligaments. All of that is supported by the tendons and the muscles of the foot and the ankle, and then all of that is kind of supported by all of the arteries and the veins. So as you can imagine, it's kind of a lot of stuff. So the ankle is a little bit more simple. It's composed of basically 3 bones, your tibia, your fibula, and your talus. It's attached to the foot is attached to the leg right at that joint. It's attached with the ankle ligaments, which are usually the ones that you're going to injure when you have an ankle sprain. Just a little tidbit that's going to kind of be a little bit more relevant later when we talk about preventative things is that the talus, right here we go. Right, this bone, it's wider in the front than in the back. And the reason why is because when you're walking, when your foot's flat on the ground, it's kind of a press fit. So the wider front kind of sandwiches it inside, and then you don't have very much movement there. So it's very stable. So when your foot hits the ground and then you go flat, you're very stable, you're not really moving. But when you go on your toes, the back of the joint, the back of the bone is in the joint, and there's a little bit more wiggle room there. So that's why you hear sometimes people say if you wear heels, you're a little bit more unstable, because anatomically speaking, you actually a little bit are. So the foot is a little bit more complicated. Many, like as we said before, many bones. But you can kind of simplify the overall structure by thinking of it kind of as a tripod. So you have your back, your front leg, and then your other front leg. The arch of the foot is made up of the bones, and all of these are supported again by the ligaments. They're held together strictly by those, and then the tendons and muscles also kind of lift it up as well. All of these joints are in some way mobile. So when you're walking, it's not just simply a hinge motion where you're going up and down or just bending in one plane. All of these joints are actually moving all at once to kind of give you that smooth, efficient force transfer and gait, essentially. But it kind of gets a little bit more complicated than that, just because the foot and the ankle are not isolated. Actually, the muscles and tendons in the foot, a lot of them end in the foot but start up on the leg. And sometimes some of them even go all the way up to the knee. So sometimes when you're walking, one muscle is kind of controlling multiple parts. It'll be relevant for later. Nerve-wise, you can kind of think of it as a plant. So the spinal cord would be your stem, and then all of the roots are the individual nerves that kind of go down and innervate all the different parts. So this picture kind of shows a little bit of a diagram of that, where I don't know if you've heard of different people talking about the levels of the spine, but different roots of nerves come off of the spine at certain levels and go to specific parts of the foot. So sometimes if you have, like, say, a back injury and it hits one particular level, there's a certain part in the foot that correlates, and that might be loss of sensation or impairment or something like that. It's kind of similar with arteries and veins. The arteries start at the heart, go down to the toes. The veins go from the toes back up to the heart in terms of blood flow. And you can kind of think of it more as a plumbing system, where it's all these pipes that are increasingly smaller the farther down you go. And if there's any blockage at any point, then you get just decreased blood flow to everything below that. And my colleague, Dr. Perez, is probably going to discuss a little bit of that once we get to some diabetic complications. So what do the feet actually do? Now you kind of have a little bit of a picture of all the different players in there. So obviously they support our body weight and anything we're carrying. There's for movement. They do balance. Not only the physical aspect of balance, where they're holding you up, resisting forces, but also the sensory aspect of balance. So proprioception is kind of the body's way of knowing where your foot is in space. So like when you step, you kind of instinctually know, well, my foot is a little bit in front of me. And the foot does that by sending signals via the nerves all the way up to the brain. Shock absorption and force transfer, we kind of touched on that, where your foot is the first thing to hit the ground, so it has to absorb the shock first, and then it kind of transfers it up all the way up through your body. And then sometimes people don't realize this, but some conditions in the foot actually are signs and symptoms of systemic issues. Like I was saying earlier, Dr. Perez is probably going to talk about some of these things, because some of the signs and symptoms of diabetes and other complications of diabetes happen actually in the foot. And sometimes you can pick up them sooner than others throughout the body. And then compensation is, like we were talking about, it's all connected. So if like say your hip is out or your knee is out, or there's some kind of deformity in the bones further up, your foot can actually compensate for some of those things and kind of absorb that deformity, do different things to compensate for that, so you can still walk regularly. So speaking of walking, it's a cycle. It's also a little bit technical, where there's multiple muscles, multiple joints. They all kind of do similar things in a cyclical manner. So point being, a lot can go wrong, basically. You have a lot of players interacting with each other, a lot of things that could happen. So it kind of brings us to the next thing, where we start talking about injuries. So acute injuries, acute trauma, you have your fractures, you have your tendon ruptures, your sprains. These are all kind of more high energy traumas. A lot of times you'll see this on during sports, just random falls, like accidents, etc. And these are a little bit harder to prevent because they kind of just happen by chance sometimes. The more preventable ones are these like overuse injuries where it's more of the muscle is being constantly micro-traumatized a little bit because it's being overused based on either the size of it or how stretched out you are, how not stretched out you are, how tight everything is, or different deformities can also cause issues with the way the muscles are working. So these are commonly your tendinitises, and probably the most common would be the plantar fasciitis. So I don't have time to go into all of them. They're all individual lectures, but we will briefly talk about plantar fasciitis since it is so common. I think I Googled this. 1 in 10 people, according to Google AI, 1 in 10 people is affected by plantar fasciitis at some point. So I thought we'd talk about it. So the plantar fascia is this thick band here. It starts at the heel and it goes all the way to the front of the foot. There's 3 different bands, but the main one is the central band here. So the itis part comes from the where did my cursor go? There we go. The itis part comes from the inflammation right here, where if the band is being pulled due to some biomechanical issue, causing it to need to be pulled over here, it actually causes inflammation right here. And sometimes that can develop into a heel spur. Sometimes the heel spur is already present. The heel spur is kind of a commonly associated thing with plantar fasciitis, but sometimes I've had patients where they have gigantic spurs and they have no pain, and sometimes I have patients with no spurs and they have like astronomical pain. So it's kind of, sometimes it's there, sometimes it's not. Commonly, you'll have pain kind of right where this picture is pointing. Sometimes there's swellings, and most commonly, people will describe their pain as pain with the first step in the morning, like right when they get out of bed, they put your foot on the ground, you stand up and they go, ooh, or after periods of rest. So if you're sitting for a long period of time, you start getting up and then right when you get up, it starts hurting. Treatment-wise, it's your rest, ice, immobilization, you have anti-inflammatory medication, and then you have kind of more preventative things, as I like to think of them, as your stretching, your orthotics, and then at the very, very end, surgery. So we kind of, with this whole lecture series, we're focusing a lot, I think, on preventing injury because prevention is better than cure, as this, I'm not sure who this guy is, but it sounded good. But it's true. It's true. Preventing the issue before it happens is always better than fixing the issue when it does happen. So to start off, stretching. Stretching is probably one of the easiest and most, probably I would say overlooked things you could probably do to prevent a lot of major injury. Not even just in the lower extremity, but also your arms and your shoulders, like in musculoskeletal in general, stretching has many benefits. So when you stretch, you're basically maintaining your flexibility, but what that means is you maintain your normal muscle length and also the proper range of motion of the joint. So if you're too tight because you're not flexible, your muscle is short and tight, and then when you pull on it, it causes damage. So the way I think about it is kind of you take a rubber band, you stretch it as far as it goes, and then you stretch it more. And eventually, it's going to snap. So that's kind of how a lot of the times this kind of plays in, where we try to make the rubber band as elastic as possible, so you can stretch it more and more. Studies have shown it reduces risk of injury, and then some studies, they're kind of mixed. They show improved physical performance and decrease of pain after activity, but others disagree. But basically, the main issues that we're kind of fighting against with this is that in general, people tend to live more of a sedentary lifestyle where you're sitting a lot for the day, you're your body is kind of more in a contracted position instead of kind of elongated when you stand. Or you have a lot of immobilization. Maybe you had an injury or something like that, and you have to do it to heal the injury. So you're in a cast or something like that, but that kind of also locks up your muscles. And then there's just not stretching at all. Sometimes people are more active, but then they're just not stretching. So in terms of stretching, how to do it the best, I guess. I basically just looked at all of these different medical websites and articles and stuff, and this is basically the summary of it. You stretch regularly and consistently. A lot of times, patients will come in and they will have a problem or pain, and then we tell them, okay, do this, this, and this, and part of that is going to be stretching. So they'll stretch very, very diligently, and then once the pain is gone, they stop. And then what happens is usually like a couple months later, they'll come back and say it came back. So I say, well, did you stretch? They said, no, I didn't think I had to. So you have to maintain the muscle too, because it is in some ways elastic, and you have to maintain the length of it by doing this kind of thing consistently. You also shouldn't feel pain. Sometimes some of my patients have come in, they said, okay, I stretched and it hurt a lot. And I was like, well, you probably did too much. There is a little bit of a slow ramp up to this. You can't just go all the way and pull your foot all the way back and hope that nothing happens. If you do too much, it's gonna hurt because your muscle, again, is too tight. So a little bit of tightness, a little pull, that's okay. But if it starts hurting, you should probably dial it back a little bit. This was also something interesting that I wasn't really aware of actually, but they recommend now that you actually stretch on a warm muscle. And what that means is instead of a cold muscle would be basically you're not using it, you didn't do anything for it yet. You're waking up straight away and all your muscles are not being used. And then they say that if you do that, you're more likely to induce injury. So instead, what people have recommended in studies and stuff is you should walk around a little bit, exercise a little bit, use your muscles first, warm them up, get the blood flowing basically, and then you stretch. And in doing that, it'll prevent a lot of injury. The other thing is stretch both sides. So the other thing that happens quite often actually is patients will come in and they'll have a problem on one side of their foot, and then we'll fix that. And then they'll have the same problem on the other side of the foot. And I said, well, did you do it? Like, what were you doing? And they said, well, I didn't do anything. And I'm like, did you stretch? No. So the problem kind of repeats itself a little bit there. So when you're doing your stretching, you should be doing like a full body kind of maintenance stretch. And we're talking about the foot and ankle and the podiatrist viewpoint, but it also goes for kind of your upper body and all of your core and everything as well. And then the other thing is stretching should be smooth and you should hold it. Because the other thing patients will do is they'll tell me, I've been stretching, and they'll kind of go like this. And that's great because it helps range of motion, but that's not really stretching. So with stretching, you want to have smooth movements and then hold it. And you hold it there for like 20, 30 seconds. And usually kind of at the end of it, you start feeling a little shaky. That's okay. And then you let it go, just kind of shake it out, rest, and then you do it again. But the holding is probably the important part that I wanted to stress there. So in the foot and ankle, very commonly, we're talking about the gastrocsoleus muscle and the Achilles tendon. So the gastrocnemius and the soleus are two muscles in the back of the leg, and the tendons come down and they kind of combine together to form your Achilles tendon, which inserts right at the back of your heel. And that's kind of the major one where people have in sports where they rupture their Achilles and their career is over. So it's a very powerful, very often a little bit overlooked, I would say, muscle, but it does influence a lot of things, whether that be if it's contracted, you could possibly have Achilles tendonitis, you could increase risk of Achilles tendon rupture, you could have pain in the front of your foot even, at the front and the bottom, kind of at the sole, and plantar fasciitis, or sometimes it also actually has an influence on different deformities in the foot as well. So it's pretty important, and that there's a reason why it's the most commonly contracted muscle. These are kind of some examples of stretching. There's many ways to do this. The wall lunge is kind of one that's just easy in my opinion. You can do it anywhere. This towel one is a little bit more for if you can't, if it's more difficult balance-wise, or you have other conditions where it's just not convenient or something like that. But also for anybody who likes doing yoga or anything like that, downward dog works too. That it pretty much does exactly this. So now we're kind of, we say, okay, cool, we're stretching, and now what? So there's also external supports a lot of the time now, and podiatry is very commonly associated with shoes and orthotics, which is what we're going to talk about next. So shoes, yes, nobody likes sneakers. They're ugly or whatever, but they're great for your feet. So I thought I'd talk about like kind of what I think would be a good shoe. So in a good shoe, you definitely need your arch support, and you definitely want, in my opinion, a stiff heel counter, which is in back here. And this is mainly, we're talking about this for prolonged activity, exercise, weight bearing for long periods of time. But the stiff heel counter is, the heel counter is this part of the shoe right here, kind of where his hand is. And that, if it's stiff, you basically, when you squeeze the back of your shoe, you can't bend it. And the reason why that's important is because when you're walking, especially on uneven ground, if you have a stiff heel counter, your foot won't bend in and out. It's a lot more supported that way. The other thing I like is a little bit stiffer and rigid when it comes down over here. Because in my opinion, if you can roll it into a ball or squeeze it like a rag, it's not doing anything for support. It's mostly just for comfort. Shock absorption, I've been seeing a lot more shoes lately. It's kind of becoming in vogue to have like a super big bottom of the shoe, and I think that's actually been helping a lot with shock absorption when we're walking on cement or other hard surfaces, just to absorb some of that and keep it off of the body. And then also probably one of the biggest ones is just, it feels good, because there's plenty of brands. People ask about, oh, what's a good brand? What shoes are great? And I'm like, well, a lot of brands are good, but you just have to try them, and whichever one you like and feels good for you, it's probably a good shoe for you, because you're not gonna wear a shoe that you don't feel good in. And then also another note, sandals, in general, I would say they're not as good and supportive controlling motion as shoes. But that being said, if you're doing like around the house or very short distances, there's a lot of newer sandals nowadays where they do have that kind of arch support and some of the features of a shoe as well. So equally as important as the type of shoe and the style of the shoe is the shoe fit. So this kind of goes into, it just has to fit, meaning it can't be too wide, it can't be too narrow, can't be too loose, can't be too tight, can't be too long, can't be too short. It just has to be just right. And the reason for that is manifold, but basically for the toe box right here, it's very common. If you have a foot deformity, if you have a bunion or a hammer toe or something like that, you'd never want the shoe to be so tight that it's riding right up against that deformity, because that's going to cause pain, irritation. Sometimes at the very end, it could cause wounds, which can lead to more complications. So when I say toe box, we're talking mainly about like kind of right here. And right here is usually where you're going to find it rubbing. So a toe box should be a little bit high, so you're not rubbing against the top of the toes, and it should be wide enough where it's not rubbing against the sides of your feet. And then the soft mesh cloth upper would be kind of up here. And this is kind of more with sneakers, but they do have like more of a cloth, usually a mesh top of the shoe, and that allows the foot to deform the shoe instead of the shoe acting on the foot. If it's leather or some of the other harder materials, sometimes it's too rigid to deform, and the deformity, instead of punching out, it'll just punch down, and it'll just irritate it all over again. Square versus round versus pointed toe, I just included that because it kind of depends on the foot type. So a lot of my patients with bunions, they come in, they're like, I don't know why it hurts. And I said, well, your shoe is a triangle. So your bunion is right here and your shoe is squeezing it. And sometimes it's not as apparent that that's the case if they have a wider shoe. Because even if you have a wide shoe and you have a super pointed toe, it's still going to squeeze your foot a little bit and irritate that part. And the other thing where podiatrists also love is orthotics. And it kind of gets confusing because I get a lot of questions about what is a good orthotic, what should I buy, what's good. But basically, orthotics are more than just an arch support. They're more than just something you put in your shoe and it gives you arch support. They do that, but they can do a lot more as well. So the orthotic is an insert that alters the way the foot interacts with the ground. And the way it does it is it neutralizes any abnormal forces and pressures that the ground is putting on the foot due to the shape of the foot and whether it has deformities or not, or whether there's other things it's compensating for or not. The orthotic we can kind of add modifications and other things to the insert to kind of offset those issues. So this is kind of just for guys' information. So the difference between an over-the-counter versus a custom. So over-the-counter, I think for the most part, I've seen them primarily for comfort. So, which isn't bad. A lot of times patients, that's all they need. But usually they're very soft, made of gel, memory foam, other kinds of things. But usually I tell my patients, go to the store, bend the orthotic at the arch, and if it bends, it's just for comfort. It's not really giving you a lot of support. Because if you can bend it, that means when you put your body on it, your body has enough weight where it's going to bend it as well and deform it. So it's not going to support your arch as well. Lately also, there's been offerings of custom orthotics at kind of retail stores, which is good because they do conform to your foot. They're a little bit better sized for your specific foot, but I would say it's probably better to think of them more as personalized orthotics rather than custom because there's no additional modification to them, meaning there's no extra pads elsewhere, there's no different materials here and there. It's kind of just that they mold it to your foot and it supports your foot, instead of just kind of being mass produced for the average foot type. Truly custom orthotics is kind of, you have to have a biomechanical exam associated with it. So you have to look at the pressures where different injuries are, different, if you have a wound or if you have a pressure point or a callus or something like that. If your foot kind of goes in versus out, if it goes forward or down, like there's all different aspects of this that you can do and different modifications, different materials we can add, different pads or cutouts and stuff like that to kind of truly make it custom for your particular foot and to kind of alleviate some of that pain that you feel when you walk. So probably the biggest preventative thing overall would be fall prevention. It's a broad topic, so I kind of tried to tailor it mostly to the foot and ankle, but there's many aspects of it, different medical issues that you might have, side effects of medication, your surroundings in general, whether that be maybe it's just too dark and it's harder to see, maybe the ground is a little uneven, but and overall your physical health. So your vision, your hearing, your strength, how you walk, your balance, your flexibility, all these things that we kind of talked about before kind of play into this as well. And it's not just a musculoskeletal issue. It's not just maybe even a doctor issue, but it's really a team effort when you think about fall prevention because there's so many people involved with this as well. Medical professionals, people that can help assist you getting different things. Your loved ones at home are usually probably the most supportive people that help you out with this. And then you're part of the team too, probably the main player, really. And then when I think about fall prevention, I think it should really be more of, instead of like a list of things you have to do, like a checklist, you kind of have to think of it, I think, more like a lifestyle change. It's adjusting your lifestyle to be more safe, basically. Whether that's changing your habits, changing how you do things, which is actually, I didn't know this either because my friend told me that that's kind of what occupational therapy does. It kind of helps you do these things because I didn't know the difference between occupational therapy and physical therapy. But she was telling me that occupational therapy will help you kind of alter your daily life activities so that you can do things safer, which I was like, oh, great, that's perfect. Especially with this. Adding different routines. Instead of doing things at night when it's dark, maybe you do things during the day so you can see better. Like it's very simple things, and a lot of times maybe we don't think about it. When we think fall prevention, you think, okay, I need a cane or a walker or something, which is true, that those are a part of it, but little lifestyle things can help too. But one thing that kind of for me being just, a podiatrist, I think posture is actually overlooked. So when you're standing, you have your center of gravity, and usually when you stand up straight and you're walking, your center of gravity is right over your feet, basically, your base of support, as the picture is saying. The problem is when you have anything that causes you to bend forward too much, whether that be sometimes changes in vision, because if we can't see something, we instinctually just go like this, and you're leaning forward, or if you have other like maybe back pain or something like that, anything that causes you to move forward actually pushes your center of gravity forward, and it pushes it away from your space of support, which is a lot of times makes it a lot easier to fall, because your center of gravity is kind of like where all of the weight is kind of centered. So if you're forward, your weight is already going down, and it only takes a little nudge, a little trip or something, and you go right down. So posture is kind of easy. You basically just stand up straight, right? So it's a little bit of an easier way to add to your routine. Sometimes it can be unavoidable if you acquire assisted devices like a wheelchair or not a wheelchair, sorry, a walker or a cane, but that kind of makes it even more important for those things to be sized appropriately. Because I see sometimes a lot of my patients, they'll come into the office, their canes are way too short, and they're kind of hunched over and they're going like this when they actually should be standing up straight with a cane. You actually shouldn't really be hunched over like that. So it's very important for the proper sizing, the proper usage of devices when they're being used, and that can actually help a lot more than just having the device in and of itself. So other things, foot and ankle specific, we kind of talked about a lot of these already. Just regular exercise, strength training, flexibility, stretching, shoes, supportive shoes, a little bit stiffer, good tread on the bottom of the shoes. You have to watch out for your old shoes. Because once your shoes are old enough, the tread on the bottom just is gone, and there's no friction on the bottom once they wear away. And then remember, again, heels add instability. Orthotics can always help, and then just simply evaluating and eliminating pain in the foot and ankle. A lot of times when you do have pain, whether it be from a little corn or callus to even to all the way up to really significant big deformities, if you have pain in the ankle, it's going to change the way you walk. So if part of the fall prevention strategy could also just be, come see us, and we'll figure out how to get rid of the pain. There's other systemic things, and one of these is the main ones we see is diabetic, diabetes with neuropathy, and my colleague's gonna take over and talk about that. So, thanks.
Thank you, Dr. Tsuchida. If I could hammer a most important message out of his lecture would be the prevention. As physicians, we will treat you if catastrophe or injuries occur, but any doctor, I think, would emphasize prevention so you can get rid of doctors. That is probably the most important aspects, not only in what we do, but your cardiologists, your endocrinologists, your primary care doctors. Okay, next speaker, Dr. Alexander Perez. He is not local like Dr. Tsuchida, but he has made home here in South Bay. He is a graduate of New York College of Podiatry Medical School. He was his residency was at Englewood Hospital, and he was a chief resident during that time. He's a Renaissance man. He can speak multiple languages, including for those patients who feel comfortable with Spanish. as well as Russian. So, Dr. Perez, for your lecture.
Thank you for the kind introduction, Dr. Kim. Since the cat is out of the bag, for those who speak Spanish, bienvenidos y muy buenas tardes. And even if you're a Barcelona fan, you're still welcome here, so, okay, we'll continue. I want to say a special thank you to the Miracle of Life team for allowing us to be here. It's a great privilege. Thank you especially to Mary Ford, and as well as to Dr. Kim for helping us set this up, as well as Ann Erigan, our office manager. So thank you so much to all of you guys for being here. Okay. There we go. So I wanted to focus again on preventative foot care, but in particular, I want to talk about that in the context of diabetes as well as circulatory conditions. These are some of the most common things that we see in the office setting, and they are in particular very important conditions because they can cause quite a lot of havoc on the feet, not just on other parts of the body. So it's really important that we take good preventative care. So these are kind of fairly serious topics when we think about it, because diabetes has so many ramifications. So we really want to care for our feet in this context. So we'll focus on that. First, some statistics, also taken from Google. The American Diabetes Association, these are for actually numbers from 2021. So in fact, these numbers have only increased both in quantity as well as in percentage. But just in 2021 alone, when you look at the prevalence of diabetes in the United States, 38.4 million Americans have that. That's almost 12% of the population. Of that, we note that there are about 30 million that were diagnosed and 8.7 million that were underdiagnosed. So it's actually a misdiagnosis more often than you might think. The prevalence, particularly in patients that are over age 65, is quite high. It's about 30%. Again, this is a few years ago. New cases arise all the time, 1.2 million. And of note, pre-diabetes, so patients that don't have full-blown diabetes yet, but are at very high risk of that, that's around 100 million Americans in the United States. So that is a very large portion of our population when you consider the fact that we're about, 350 million, I believe, roughly? So it's an important thing to consider diabetes in the context of our feet, because in fact, our feet is one of the first places where it manifests. So it's really important to keep that in mind. So why does prevention matter in diabetes? Essentially, we want to prevent wounds, ulcers, so open wounds in the feet, which can happen in the context of diabetes. And when we have wounds, that can cause infections. Infections can lead to, unfortunately, amputations, and that can even lead to limb loss. And unfortunately, we do see that. There are also issues of gait and mobility that are associated with diabetes and circulatory issues. So first we're going to talk, you see this kind of little, how do I do this with the mouse? Oh, there we go. You see this sort of stair-stepped description of diabetes, neuropathy, ulceration, ischemia, infection, amputation. First, we're going to talk about neuropathy and what that has to do with diabetes. So peripheral neuropathy, it's kind of a big umbrella term for damage to nerves outside the brain and the spinal cord. In patients that have diabetes, what occurs oftentimes is we get damage to the nerves, and that damage to the nerves can result in other issues. Typically, it presents in a few different ways. So if you look at the little schematic down there, it shows some ways that it presents. Patients will often complain of their feet feeling numbness. Another common one is feeling kind of hot or cold, especially a burning sensation. You tend to hear that. Very commonly, we hear about tingling in the feet. A very common description you'll hear is sort of like this sensation of ants crawling on the feet or on the legs. Oftentimes pins and needles, sharp stabbing pain. Ironically, it says hypersensitivity. Despite having loss of sensation, you can actually have an increase in sensation to pain. The pain tolerance threshold can go down. So you get all these kind of symptoms that arise that are very much indicative of neuropathy. So when we see that in patients with diabetes, we get particularly concerned. Although it is present in diabetes, and that's the most common cause we see, it is not only due to diabetes. There are a whole list of things. A very common one is excessive alcohol consumption. We call alcoholic neuropathy. You can have it from vitamin deficiencies, nerve damage from trauma, infections, chronic liver or kidney disease. You can see that with certain cancers, especially chemotherapy can cause that. Some genetic conditions, autoimmune inflammatory conditions. And then I also want to note idiopathic neuropathy, which basically is just a big term for we have no idea why it's happening. Some people just get it. And when that happens, we also need to be mindful of that. So why it matters, again, I just want to emphasize it is most common in patients with diabetes. That loss of sensation that we see can result in, imagine you're walking. When we walk, we have pressure points on the feet, right? When we walk on our feet. Normally, we feel all of that. But when we start losing the sensation, all of a sudden, these pressure points build up. And we don't even know it because we can't feel it. But once that loss of sensation is there, we can open up a wound in those areas. We also can develop calluses and things like that, which in and of themselves can become problems. But the wounds that develop become problems. So a loss of sensation could lead to ulceration, meaning an open wound. And an open wound can then conceivably lead to infection. And infections, when they get bad enough, can lead to amputation and even as much as limb loss. The other thing that we need to be mindful of too, once we start, imagine you're losing the sensation, right? You're feeling numb. You can't really feel the feet so well anymore. What ends up happening is our balance is now off and we're not able to feel the ground the same way we used to. So there's a very high risk actually of fall associated with neuropathy. So gait and balance actually are very much compromised if the neuropathy gets severe enough. So again, loss of sensation leads to increased pressure due to abnormal loading on the bottom of the feet, right? Those pressure points, we don't really notice them anymore because our sensation's not as good. Another thing that's really important here is increased risk of trauma. So barefoot walking, terrible idea. And imagine if you can't feel, it's very easy to step on something, attack a nail. We see these are things you see come through the ER, especially with patients that have neuropathy. And all of a sudden, you step on something and you don't even know it. It does happen where a patient will come in and they don't even know that they have something on the bottom of the foot, or they don't know till someone else notices, or they see bleeding, or they see, something unsightly. So it's really important to always be well shodden, because if we're not, we don't have something on our feet, it's very easy to have trauma, particularly when we have neuropathy. Another one, I think Dr. Tsuchida had mentioned it briefly, is the friction from shoe gear. So friction from shoe gear, right? Shoes are just not the right fit, and that friction can cause a wound to happen if there's decreased sensation, because you might not even feel it until all of a sudden you take off your shoes, take off your socks, and you go, oh, whoa, where did this come from? So it's a really important thing to address. Prevention. So some of the big things here, managing our underlying conditions. So again, since diabetes is the most common reason, it's really important to maintain very good blood glucose control, right? Regular follow-up with the primary care physician, with your diabetes specialist, and periodic foot checks with a podiatrist is really, really important, because otherwise we may not know what's going on. Avoiding excessive alcohol consumption, avoiding smoking, these are all things that can worsen neuropathy. Sometimes we even have to have vitamin B12 supplements. So there are things we can do that are preventative, but what's really important is making sure we're getting regularly checked to see, A, is neuropathy present? What's the severity of it? What can we do to prevent? Another important thing that we see very commonly are circulatory conditions, what we call peripheral vascular disease. So it's kind of a big umbrella term. It's a progressive disorder of reduced blood flow to a part of the body outside of the brain or the heart. So When we see peripheral vascular disease, it typically presents in the legs, these circulatory conditions. They're not exclusive to the legs, but very commonly there. So we have all these arteries. You can see the iliac arteries in the abdomen. And then as we go down to the lower extremity arteries, those of the legs and the calves, those are the ones that we really tend to see these decrease in blood flow. So what happens is we get a buildup of plaque in the arteries. And once that buildup of plaque starts to happen, you can see narrowing of the blood vessel, and all of a sudden, there's not enough blood vessel getting down to the tissues. If it's bad enough, you can see a clot that forms. And once clotting is there, then we can get some serious problems to the lower extremities. So some risk factors to consider. In particular, diabetes is a very big risk factor for circulatory issues in the legs. In fact, really, it's kind of the combination that's most concerning is when you see diabetes along with peripheral vascular disease. And in particular, smoking. Smoking is the #1 contributor to circulatory problems in the legs. So aside from that, also as we grow older, age 50 or older, that tends to be more common. When we have a body mass index over 30 or any family history of cardiovascular disease, high blood pressure, high cholesterol, those are all things that can contribute to circulatory issues. Again, it's really important to emphasize it because it's so important. Anyone who's a smoker has about a 3 to 4 times more likelihood to develop peripheral arterial disease. You're about 300 to 400% times more likely. Not only that, but all of all deaths that are related to peripheral arterial disease, about a quarter of them are linked to tobacco use. In fact, there's also a strong correlation to the disease progressing more rapidly, or if there's any kind of intervention needed, that failing, and risk of mortality. So the most critical thing we can do to prevent these circulatory conditions in the legs is to stop smoking entirely or just not start in the first place. Why it matters. So these are kind of unsightly pictures, but these are probably the nicest ones I could get actually online. They get uglier only from here. So when we have not enough blood flow getting down to the lower extremities, these tissues essentially die. And so what we see here is essentially gangrene. So gangrene can develop. That's a very unfortunate outcome, and it does happen. Additionally, we can get ulcers that form, right? When there's not enough tissue, not enough blood flow getting down to these tissues, all of a sudden wounds don't heal. They just don't want to heal because there's just not blood getting down there. And so it's very easy to get infections which can then lead to amputation and limb loss. And once gangrene is developed, if this tissue itself is dying because there's a blockage, there's not enough blood flow getting there, then that always leads to an amputation, generally speaking. So it's really quite important to look at peripheral arterial disease, look at circulatory issues. Symptoms, what do we look for? How do I know I have it? So some of the big things here, cramping. We tend to get a lot of cramping in the thighs, in the legs, in the feet. Particularly with walking, it's very common to see someone that says, I can only walk a block or two and then I have to sit down because of the pain. That tells me there might be a circulatory problem going on in the legs. Or if that pain improves with rest, that's another thing that might be an indicator. If there's pain even at rest, that tells me it might be worse than we thought. Developing wounds more easily, that's another indicator, especially if those are wounds that are slow healing, that just don't want to heal. That might tell me there's a circulatory issue going on. Color changes to the feet and legs, shiny skin, especially we tend to see that, or absent hair. If you see that there's no hair on the skin of the feet or the legs, that's another indication that there may be circulatory problems going on. We also, believe it or not, have pulses down here, and we check those pulses. And if the pulses are weak or absent, that's another strong indicator that there may be a circulatory problem going on. So these are important things to look for to say, might there be a circulatory thing going on? prevention. It's funny to see those ads that they used to be. And, you know, there was a time where that was in vogue. But we have a lot more information now about peripheral arterial disease and about smoking. So once again, please don't smoke. That's the best preventative thing. Another thing is exercise. You know, when we exercise, especially when we walk and we move about, we're actually pumping blood down to the legs. So if you see any physician that diagnoses that, they'll probably tell you need to walk more. It may be difficult to walk if you're having that leg pain, but that's an important component to that. And of course, keeping our diabetes, blood pressure, cholesterol in check is very important. Also, again, getting regular foot checks, seeing a podiatrist is important. The reason is a lot of people have peripheral arterial disease and are asymptomatic. They may not have any symptoms. Roughly about 40% of people with PAD do not have all these classic symptoms. They don't have the leg pain and they're not constantly in pain, but there may still be narrowing of the arteries going on. So what can we do as general foot prevention here for these medical conditions? One very straightforward one is check your feet daily for any wounds or any sores. Again, with neuropathy, you may not feel it. You may not even notice it. So we check our feet daily. If we're unable to do that ourselves, have someone else assist us. Or you can even use a mirror, check the bottom of the foot, right? We really want to make it a habit to check daily, particularly if you already know there's a diagnosis of, especially neuropathy. So another thing too, it does happen. People get burned sometimes going in the shower, for example. So it's very important to check the water temperature with the hands. Sometimes we can actually have neuropathy in the hands or with your elbow before you go in so that you don't prevent getting a burn when you get in the shower. It sounds crazy, but it happens. Dry the feet well after washing, right? We don't want a lot of moisture there. Now, moisturizing our feet is a great thing to do. However, never in between the toes. The reason is it's a nice little moist environment and it's a great way to get an infection. So fungal infections are actually quite common this way. We get a nice humid, moist environment that's like a little oven and fungus goes, yes, I love this. It can actually, and if the infection gets worse, fungal infections can actually be, if they're severe enough, superimposed with a bacterial infection and you can actually get a full-blown wound infection there too. That does happen. So we really never ever want to put lotion in between the toes. Anywhere else, great idea. Trimming toenails, doing that with care. We want to avoid cutting them too short, rounding the corners. This is one of those things, especially in patients that have the diagnosis of diabetes or circulatory components or any sort of neuropathy. It may be best to have a podiatrist or some professional do that, simply because these are higher risk. If we get a cut or a wound, right, and you have poor circulation, that might be a problem of healing that wound, right? If you get a cut or a wound and the blood glucose is not under good control, high blood glucose means poor ability to heal a wound. They go in the opposite direction. They're inversely proportional. So it's important to have another professional do that for you. Other things, I have to say it again, avoid barefoot walking. I know it sounds crazy, but that does happen. You see that in the ER. Stepping on a nail, rusty nail, and then, you know, all hell breaks loose after that. So it's very important never to be barefoot and to choose the shoes carefully. I'm not going to step on Gavin's toes, so to speak, but shoes need to be really well-fitting and accommodative, because if you don't have good sensation, it's very easy for the friction of the shoe itself to cause a wound. So we want to be very, very careful, right? He talked about, you know, making sure they're not too narrow, right? None of that triangle, all of that kind of stuff's really important to think about what kind of shoes we're wearing when we have issues of poor circulation or issues of diabetes, especially with neuropathy. Keeping the shoes clean, shoes and socks clean. Right, very easy to get a fungal infection if we got a nice, humid, moist environment and everything's dirty. Keeping everything very, very clean, and you may want to even consider diabetic or orthopedic shoes to make sure they're absolutely accommodative and really the right fit for your foot. So Again, socks clean. Warm socks, great idea. If you have poor circulation, keep them warm, right? However, um, we want to avoid things like heating pads, electric blankets. People do get burns from these kinds of things. You don't, I haven't seen it as much here in Los Angeles. I used to see it more in New York. You know, somebody accidentally would rest their legs on the radiator and then get a burn. You would see things like that. But you can also see that with heating pads and electric blankets and that sort of thing. So it's important to be careful with that. And again, it's really important to have routine foot exams. So you want to see a podiatrist on a regular basis. You know, have those feet checked, make sure circulation's doing okay, make sure diabetes is in check, make sure neuropathy is in check, and make sure we're doing all of the preventative care possible to prevent these things from progressing into real problems like wounds and infections and amputations, God forbid. Routine foot care is also important, right? As Dr. Tsuchida was mentioning, we do have different foot types and sometimes different deformities that may predispose us to things like corns and calluses and the like. You know, you don't want to go home and grab some pair of clippers and go after these calluses if you're predisposed to getting wounds, right? So come to the podiatrist and we can do that and take care of those things in a way that is safe. Especially if you got diabetes or peripheral vascular disease. So a summary of the key points. Peripheral neuropathy is a condition that's very common in patients with diabetes, though it's not only seen in diabetes. Because our nerves are essentially losing their sensation, we can get ulcers, amputations, and even limb loss. You can lose the leg. Similarly, with poor lower extremity circulation, we commonly see that, especially in patients who smoke, who have diabetes and are over age 50. That can also lead to gangrene, infection, ulceration, amputation, and loss of limb. So we want to do every preventative measure we can to prevent these kinds of negative outcomes. So regular checkups with your podiatrist, that's probably the best thing you can do. And of course, seeing your primary care on a regular basis. If you have diabetes, seeing your diabetes specialist as well. And that's pretty much all I got, so thank you.
Thank you, Dr. Perez. So the next would be if you guys have any questions, we'll be happy to field them. And do you collect them? Okay.
Members of the committee will have paper and writing implements if you need it. So we'll collect the questions, give them to you. If we yell them out, they can't hear it on the audio.
Okay. Thank you. Sure. Sure, thank you. Thank you. Oh, yeah. Wow. 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 Oh, I think I have somebody. Oh, thank you very much. Thank you. Thank you. Oh, thank you. So, okay. Um, Please get your refreshments. That's okay. But due to time restrictions, I'm going to begin. I hope you guys don't mind. Okay. And I'm going to field questions, and our expert physicians will discuss them. Dr. Perez, can neuropathy cause itching sensation?
Testing one. There we go. Okay. I will say anecdotally, I have heard that as a complaint. I've not in any literature generally seen that as a common thing that you see directly related to neuropathy, but I have seen that anecdotally. And it's not uncommon. Let's say we have diabetes, because when we have diabetes, it's you can think of it as being in some sense immunocompromised. We are actually at a higher risk of getting fungal infections. That is a real thing. So it's not uncommon to have patients who have diabetes and also have fungal infections in the feet. And that would be more likely the source of itching. Not necessarily the neuropathy itself, but it might be something you will also see commonly. I hope that answers the question.
All right. Dr. Tsuchida, two-part question. Well, no, one. How is a bunion corrected? Breaking bones sounds too painful.
Hello? Oh, it's on. Okay. So It's kind of tricky because basically if you have a bunion deformity, the only real way I would say to correct it is through surgery and to break the bones and move it and then put hardware in there to make sure that the deformity doesn't come back. That being said, there's other ways, like surgically you can do it, but um, in terms of the pain part, you're under, like we numb you up, so don't worry, you won't feel it. But yeah, for bunions, it's kind of hard because a lot of times I tell my patients, like, look, if you have pain from your bunion, that's when you should fix it. If it's not bothering you and you just have a bump, then there's shoes for that. They have a lot of wider shoes. You can kind of pad it or offload it to some degree. But if it's actually causing you like functional deficits in your day-to-day, that's when you might want to consider surgery. So there are other things we can do for bunions besides just cutting.
Thank you. Dr. Perez, what should you do if you have toenail fungus? Is it just cosmetic or is it a medical problem?
That's a good question, thoughtful question. I feel like we could do a whole lecture on fungal toenails, though. So again, like I was talking about earlier, you know, when you have a fungal infection, sometimes fungal infections can also be superimposed with bacterial infections. So although it's not as common, yeah, it's something that should generally be treated as much as possible. And there are quite a few things that can be done. Generally with fungal infections, whether we're talking skin of the feet or toenails, there's generally like a couple ways we can go. We can go either with topical medications or we can go with medications taken by mouth. So something you put on versus something you take. Generally speaking, topical medications are less effective overall, but safer. Oral antifungal medications, the ones we take by mouth, are generally stronger and oftentimes more effective, but they do carry more risk with them. There is some risk of liver damage in particular that we have to be mindful of, so we often have to be monitoring things like blood work of your liver and so on, just to make sure that it's being done safely. So it really is kind of case-by-case basis. You know, it depends on your past medical history, what's safer, depends on the severity of the fungal infection, depends on what have we tried already and has it worked, you know. So there are kind of a few different things to think about, but it's certainly treatable and it definitely should be treated.
One treatment that I would also add is the more newer treatment would be the laser treatment for fungal toenails. Definition of cosmetic problem probably depends on your insurance company and what is covered or not. That would be something that is a different discussion as well. Okay, Dr. Tsuchida. I like this question. What can you do specifically to strengthen feet and ankles?
So the easiest answer is find a physical therapist, become their best friend, and then make them do physical therapy for you. But realistically, honestly, just doing something, moving, walking will oftentimes kind of support. There's other like resistance band exercises you can do as well, where you move your foot and then you pull the resistance band in the opposite direction, and it kind of just helps basically strengthen that muscle in particular against resistance. And like all of these are on YouTube or Google or stuff like that. There's videos on them. You just have to type in like ankle strengthening exercises or instability or muscle weakness in the foot and ankle, and usually a lot of these will pop up. But a lot of it is exercise, just plain old exercise too.
All right, Dr. Perez. What can be done to alleviate pain on the top of the foot due to the severe osteopenia and bone spurs?
A lot of great questions. So when we have bone spurs on the top of the feet, oftentimes we're looking at some arthritic changes going on there, commonly. So there are kind of couple different ways, again, we can kind of deal with these things. So conservatively, which ideally would like to start conservatively with this sort of thing, we can do things like accommodating, padding around the area to accommodate it. That's one thing. Make special considerations for shoe gear, shoes that are really going to accommodate that. Sometimes kind of depends on what it is. If it is an arthritic change, sometimes we can go down the steroid injection path. Sometimes that can be helpful. Sometimes if we have a really prominent spur, a very prominent bone there, sometimes we have to surgically treat it and kind of shave some of that bone down. So there are different modalities and kind of a range from most conservative to more aggressive, depending on the severity of it. And of course, if we're talking osteopenia and osteoporosis, at that point, I say we need to get a DEXA scan and talk to our primary care physician, because there are things that are systemic going on when we're dealing with that, osteopenia and osteoporosis, more than just simply a bone spur on the top of the foot.
All right. Dr. Tsuchida, this is a question from audience from Zoom. Could you explain what was stated concerning insole orthotics other than being comfortable? You mentioned something regarding bending insole.
Yeah, so usually I tell my patients, orthotics can kind of come in different forms, where some of them are a lot more comfortable and flexible, and then some of them are more for support of the arch or other parts of the foot. So the bending part was basically when I was I usually tell my patients, when you go to the store and you're looking at different orthotics, I can't ever tell you this one's a good one, this one's a good one, this one's a good one, because there's so many. So what I tell them is if I'm telling them for support in terms of the insoles, go to the store, try to see, usually they'll let you take them out of the package, and then just bend it right at the arch. And if it bends right at the arch, that's usually more for just comfort. It's going to add a lot of just soft cushion, some shock absorption. But if it doesn't bend and it's a lot more rigid there, it'll actually support the arch a lot more.
I also like this question. Dr. Perez, what happens when you roll your ankle? What does it mean when you roll an ankle? Is it ligaments?
That's a solid question too. Love it. What does it mean when you roll your ankle? So rolling your ankle is basically code word for an ankle sprain. So if you can kind of visualize with me, we got an ankle here, right in between my hands, okay? And this ankle, we got ligaments holding everything together. Now, all of a sudden, I'm walking and I'm having a lovely time coming home from dinner, and there is a misstep right here, and I misstep and I just twist. The ankle suddenly twists. When that sudden twist happens, the ligaments that are holding that ankle together are suddenly attenuated. They're loosened. Sometimes they are ruptured. And so when we roll the ankle, we are spraining the ankle, which means we are tearing ligaments. So what often happens when we have a sprain is now we have instability of the ankle. In other words, it's much more easy for me to roll it again. So oftentimes now we have to start dealing with different things like, well, if we're getting into treatment, things like physical therapy, right? Who becomes our best friend at this point too? Sometimes bracing, sometimes if it's severe enough, sometimes even surgical options. Because if we continue to resprain, then we may have to think about things more than just ankle strengthening and gait training and so on. So yeah, great question.
All right, another Zoom question from my wife. When will you be home? Dinner's getting cold. No, just kidding. I'm going to my mom's house. Okay, Dr. Tsuchida, um, do you only recommend ice for plantar fasciitis or heat? Is Epsom salt soaking helpful if there is swelling?
So yeah, Epsom salt's pretty good for swelling just in general. But for icing and warmth, for plantar fasciitis specifically, I would definitely recommend ice. Heat is a little bit kind of trickier, I would say, because they do say that when you have an acute injury, ice for the first 24 to 48 hours, and then after that, heat. But the problem with plantar fasciitis is that you're walking, so you're kind of you have the initial inflammation, but then when you walk, you're kind of adding to it as well. So in general, I would probably just go with ice.
I'll give these doctors a break, and I will field this question. When it comes to diabetes, were you referring to both type 1 and type 2? So the complications that arises from diabetes itself, it can be type 1 or type 2. Any uncontrolled diabetes can lead to complications such as peripheral arterial disease or neuropathy, which will complicate other foot issues. Calluses, quote unquote, calluses can be an issue. To what degree can calluses become an issue? Is a little callus on the heels normal? So a callus, some people call it corn, is a thickened skin, and that usually happens from a pressure. And abnormal pressure causes this thickening of the skin, and with the additive effect, that will cause degeneration of skin underneath that, which is known as ulceration or sores. And they become the portal for infection to occur. And if it deepens, it can get down to the level of the tendons or bones, which increases the risk of limb loss. So for the most part, in a healthy individual with no significant issues, callus corn, you can live with that, maybe cause some uncomfortableness here and there. But people with diabetes and neuropathy and other complications, they can be a source of cascading of events into something that will be more devastating than otherwise a healthy 20-year-old. So when you see a podiatrist, what they will do is examine your feet for any thickened skin, trim it to evaluate the, not only to relieve the pressure, but also to see if there's any underlying pathology that we need to address timely. Timely addressing it will prevent deepening of the wound or the infections. Okay. Who's next? Dr. Perez? Okay. What about varicose vein? Does it cause PVD?
A lot of great questions. So varicose veins are kind of within the umbrella of peripheral vascular disease. So it can present in a couple of ways. I focused essentially on the arterial aspect of it. In other words, the blood coming down to the foot. But we can also have conditions where there is difficulty of the blood coming back up the foot. And so we can have venous stasis disease, which is a different manifestation of the same kind of thing. We can also have varicose veins, varicosities. Varicose veins, in some people, they're not particularly painful, and it's just something that's a nuisance, but sometimes it can actually be a very painful condition. And once we're starting to get into that category of things, we generally need to get to see a vein specialist, in which case there are multiple treatment modalities that can be used to address varicosities. But yeah, when we talk about peripheral vascular disease, it's not necessarily only the arteries we're talking about. It can actually be more complex than that. And we can have a mixed etiology where we have problems, both the blood getting down and the blood getting back up. So it's one of those things at that point, we generally have to start talking about seeing a vascular surgeon and maybe seeing a vein specialist and seeing what things can be done to deal with the painful vein condition too. So
I'm going to some of these questions are kind of similar in a way. what if they have tried, Dr. Tsuchida, what if they tried custom orthotics and it was not comfortable? And do you also, what can you say about custom shoes, not just custom insoles?
So, I mean, custom orthotics are custom orthotics. You can alter them. So if they're not comfortable, sometimes it's just, I mean, there's many different ways it could be wrong. Sometimes it's too stiff, sometimes it's too soft, sometimes it's not measured right. I've seen that too, where just the lab doesn't take the impression that we send correctly. So if they're not comfortable, usually you just take them, you just come back to your podiatrist, say, hey, I don't like them, they're not really working for me. And then you kind of work and try to figure that part out, to kind of figure out what the issue is on why it's not comfortable. For custom shoes, it gets a little bit tricky because sometimes I've seen patients have, when they say custom shoes, they just mean you get kind of a catalog and you pick a stylish shoe. And other times I've had also patients where it's actually a true custom shoe because of a deformity that they have. So they'll actually like make a whole mold of the foot and the ankle and the leg, and fabricate a whole new shoe to accommodate those types of deformities. I think in general, unless you have a really big deformity, you probably don't need a custom shoe. You can probably find one that's accommodating enough for the insole, or that fixes most of your issues, but they do exist. Custom shoes are a thing.
Okay, Dr. Perez. How do I know if my foot pain is something I need to see or do and I don't see an open wound?
I mean, the answer on this one, I'd say, is when in doubt, check it out. Thank you. Thank you very much. I mean, that's the reality of it. If you're unsure, right? Because I know the talk I gave was, talking about a little bit more like heavy, conditions. But the reality is, if those conditions are left underdiagnosed, untreated, right, they can be serious. So if you're unsure, is it neuropathy? Do I need to get it checked out? Do I have poor circulation? Do I need to get checked out? Don't question it. Just get it checked out, and then you'll have a definitive answer. And I emphasize it simply because these are serious conditions. We do see patients, right, routinely that really do have to go to the ER, sometimes have to go under surgery and have amputations and things like that. It does happen. So rather than wait, just get it looked at. Nice and easy.
Dr. Tsuchida, there's two questions, two separate questions. Does complex regional pain syndrome similar to neuropathy in legs and feet?
Yes.
Did you hear me?
I think,
Oh, okay.
I think like, the question's kind of hard, but to understand, but basically, yes, CRPS does exist. It does exist in the foot and the leg, and it is actually very difficult to diagnose and treat. So for me, it's a team kind of approach again, where the pain specialists are involved, neurologists can get involved, and we're involved. And we kind of attack it from different modalities because, yes, it can present similarly to neuropathy, but there's usually more involved than just that.
Even though some symptoms manifest in the foot, that doesn't necessarily mean that we treat them. It is true that we recognize disease process or pathology, but sometimes some of the conditions that actually occurs in the foot is better served by other specialists. Patients with a complex regional pain syndrome, used to be known as RSD or reflexive sympathetic dystrophy. Those are better served to be treated by the pain specialist, and he or she normally have a team, including physical therapists, to treat those conditions. We will absolutely assist other specialists, but just for if one of you guys are suffering from complex renal pain syndrome, I strongly advise seeing a pain specialist regarding that. Okay. Some of them are kind of redundant. How should corns and callus be cared for if done at home? Any special preventative exercises to any pain under the big toe? Any special exercises to prevent big toe pain? Sorry, I'm just reading it off.
So, I mean, I don't have anything specific because there's a lot of reasons why the big toe could be in pain. It's like it could not even have anything to do with musculoskeletal. It could just be vascular, actually. You might not have blood flow there, and then any exercise would probably help a little bit. So it's kind of hard to say, I would say. I can't really give a good answer for that one.
I also do not have any financial interest, but big toe pain, have you guys heard of a sneaker called Hoka brand? Though that's a job killer right there for a podiatrist. It's for people with pain in the joints, in the toes. They are very helpful. Now, but they can also, because of the shape of the foot, some patients can cause some issues in the knees. So, just because it worked for your next door neighbor, your cousin, doesn't mean it works for you. It's Hoka sneakers, you may want to try it if you don't really have any complications. And also, Hoka sneakers is not really for very elderly. Because of once again, it has more of a rocker and thick soles, it can cause some instability when you walk. So I strongly advise if you're going to try the Hoka sneakers or any of sneakers with a thick sole with a rocker, kind of try it. Hoka, yep. Try it around, try it to see how you like them, okay?
Those are the same Hokas I have.
All right, so I will end with this one. You guys know, this is for my kids at home. Do you guys know what kind of car a podiatrist drives? Tow truck.
I'm sorry.
So one of you asked, do feet get wider as we age? Does bare feet walking help with foot strength? So it is very common for you to notice that your feet actually may widen or lengthen as you get older. Not because you're growing, but just like everything, we can't overcome gravity. And there's a wear and tear. The tendons and the ligaments are holding the foot structures together, but with gravity, the arches will collapse. But because of geometry, when it collapses slightly, your foot will lengthen. And also, we all get arthritis and tendonitis. And when you have arthritis, tendonitis, it swells. So it is not an uncommon reason, not uncommon for you to see your foot size, you were wearing size 10, and now all of us wear 11. It's okay. It happens. I agree with the other doctors regarding barefoot walking for the most part. Barefoot walking is not recommended for people with medical complications such as diabetic peripheral neuropathy and peripheral vascular disease for all the reasons that we discussed. But it is true, there are people who are raised, I don't know if you guys are soccer fans, but Pele has a history, has a story about playing soccer with no shoes. If you grew up since you're a child where you are not really wearing any shoes, your foot adapts to whatever the environment that you're in. But I doubt that any of us really grew up with no shoes. We were dependent on shoes since we were a child, and our body adapts to that. And all of a sudden, as a grown person, you're going to go, I'm going to start walking in a barefoot shoes. Maybe some people will do well, but it's not for everybody. So just like anything, you can certainly try it, but I think the most important thing is that you need to listen to your body. Your body will tell you, this is a no-go. Or your body will say, maybe we can do this. So be honest with yourself, discuss with your physicians, and hopefully you'll have a better foot and ankle health rest of your life. You can give these advices to your family, friends, neighbors, and we appreciate the committee for inviting us to the lecture. We appreciate all of your audience home here, and thank you for your time.
Thank you.
Thank you.